It's really a great pleasure to be here on the platform of Tata Sky Fam Health at Eros Hotel, Nehru Place, New Delhi, India, on a very important mission. And Mission India has got a very important theme, and the theme today is how to attack heart attack. Ladies and gentlemen, it's a real problem. Lot of people die at home, they die at workplace or on the roadside with a heart attack. 60% of patients just are not able to reach in a hospital in time. It's a matter of great concern. I'm sure you all know that 3 million Indians have heart attack every year. That means 30 lakhs Indians have heart attack every year. If I talk of Delhi, there are about 100 heart attacks every day. One heart attack every 15 minutes. So we have to introspect. What should we do? Where are we going? Do you think heart attack can be salvaged only by doctors? It's not true. There has to be education campaign. There has to be awareness campaign. Public should be a part of it. All physicians should be a part of it. Paramedical staff has to be part of it. Nursing has to be part of it. If we all work together, including various organizations like SOCHAM or SCOPE or CII or PG Chamber of Commerce or Rotary or Interville. Rotary took a lead to eradicate polio. I'm sure nobody can lead to eradicate heart attack. But why should we get heart attack at a prime of life when you are 40 or 30 or 50? That's the main agenda today, to discuss what should we do to prevent the heart attack, to attack the heart attack, and what we should do after the heart attack. So I think we will talk on every aspect. 4 components are very important for our panel discussion. The first is, what are the risk factors which are responsible for a heart attack? Conventional risk factors and the new emerging risk factors. Then what is heart attack? What can we do in the family, in the community, so that we can prevent the heart attack to a great extent? And the third important component is, when the heart attack occurs, what we should do so that we attack the heart attack effectively, and then once the patient is discharged from the hospital, what he should do after heart attack. It's a really great honor for me and great privilege that I have with me such an eminent faculty of international repute from North India today. And I'm sure the second phase, we will have people from South India, so it becomes a pan-India campaign. And it is going to intensify and sensitize every individual so that he has a right to live in this world with a healthy heart. I would like to introduce, to my right is Dr. Vinod Sharma, a very eminent cardiologist. He is the Deputy CEO of National Heart Institute, a very prestigious institute in Delhi in east of Kailash. Dr. Vinod Sharma, you are welcome to this platform. To my second right is Dr. J.P. Sani, a very eminent cardiologist who is the chief and the chairman of clinical and preventive cardiology in a very prestigious institute of Delhi, Sir Gangaram Hospital. Dr. Sani, sir, most welcome. To my left is Dr. Vivek Kumar, the director of Cath Lab and Electrophysiology in a very prestigious institute of Delhi, Max Heart and Vascular Institute, Saket. Welcome, Dr. Vivek Kumar. To my second left is Professor S. Tiwari, who has come all the way from Lucknow. He is a professor of cardiology at SGPGI, Lucknow, a very eminent person, a very eminent interventional cardiologist. To my extreme left is my very close friend, a very eminent cardiologist, Dr. Ravi R. Kasliwal, who is a very eminent person, chairman of preventive and clinical cardiology at Vedanta, the MedCity at Gurugram. And our objective is very clear, as I told you, is what we should do to attack a heart attack. We should act now to impact globally. That's our main theme of education initiative. First of all, my first question is to Professor Tiwari. who has come all the way from Lucknow. Dr. Tiwari, I think it's very important for us to understand what is heart attack? How does it occur? Can you just tell us what a public should know? What is heart attack? How does it occur? What are the manifestations of the heart attack? Dr. Tiwari, sir.
Hello, sir. Heart attack basically means the various obstruction, blockage in the arteries which supply blood to the heart, and we call as in a medical term the coronary arteries. Everybody has 3 coronary arteries, and the blockage may occur at various stages of life. Usually this blockage occurs in the elderly populations, more than 65 years of age. But now we do see patients who are young, below 45 years of age, and we call as a premature coronary artery disease. It can happen to a male patient, it can happen to ladies also. In our day-to-day practice, we do see almost 10 to 20% patients who are coming to have with blocked arteries who are less than 40 years of age, and we call as young coronary artery disease. So for India, who has a huge population of young people, should be aware why this all happens. Initially, there are layers in the arteries which get roughened up like the wall of the room, and on this roughest surface of the arteries, the blood get clots, and this gradually progresses. There are different reasons for getting these blood cells get accumulated at one portion of the wall of the arteries, and gradually it progresses over the years, and this may cause blockage. This blockage may be a very minimal, or it can occurs to lead to 100% blockage. Usually these blockages are silent. We don't realize what is going on unless it get completely leads to some symptoms, and the basic symptoms is chest pain, a classical chest pain over the center of the chest. It can radiate to left side predominantly, it can radiate to left arm, it can radiate to jaws, it can radiate to back, between the upper side of the back. But sometimes it leads to only severe sweating and nausea and vomiting and extreme weakness. People say that I cannot speak, I cannot walk. Anybody who has experienced this chest pain we call as angina remembers lifelong. So there are different stages of block and different way of pattern of symptoms. Sometimes patients don't have no symptoms, and it around 30% of populations, the first symptoms that person can drop dead. So it is a very uncertain way of presentations. In young population, it is most of the time atypical. Young person says that it is a gastric symptoms, it can happen to because of some gastritis. So but if this atypical symptoms occur regularly, so one should be very cautious and go to a doctor to see.
Professor Tiwari, I think given a very nice expression कि जो हार्ट अटैक होता है, जो हार्ट के अंदर धमनियाँ होती हैं, वो धमनियाँ में खून का थक्का जम जाता है, और जब थक्का जम जाता है तो खून का सप्लाई हार्ट की मांसपेशियों में या हार्ट के मसल में कम हो जाता है। लेडीज एंड जेंटलमैन, यही होने से हार्ट अटैक नहीं होता है। जो हार्ट अटैक की जो स्पार्क होती है, जिसको हम वेव फ्रंट कहते हैं, वो हार्ट के इनर पोर्शन से शुरू होती है, फिर मिडिल पार्ट में आती है और फिर सामने के पार्ट में आ जाती है और थ्रू एंड थ्रू हो जाती है। इसमें 3 घंटे लगते हैं। इसी कारण कहते हैं हार्ट इज मसल, मतलब 3 घंटे में जो करना है कर लीजिए। अगर हार्ट अटैक को बचाना है तो 3 घंटे में उसका कुछ ना कुछ उपाय करना पड़ेगा। इन अदर वर्ड्स वी से दैट हार्ट इज जियोपार्डाइज्ड, द मसल इज जियोपार्डाइज्ड, वी हैव टू salvage the jeopardized myocardium. And you say if a patient reaches in hospital in 3 hours, वेरी डिफ़िकल्ट। आज की दुनिया में 10% या 12% पेशेंट को अगर हम प्राइमरी एंजियोप्लास्टी करें तो बच जाते हैं। मैसेज बहुत क्लियर है। नो, देयर इज़ नो डाउट दैट द प्राइमरी एंजियोप्लास्टी इज़ ए गोल्ड स्टैंडर्ड, लेकिन लोग पहुंच नहीं पाते। तो लोग पहुंच नहीं पाते तो वो ट्रीटमेंट का फ़ायदा नहीं हो पाता है। और मैंने पहले कहा कि 50 से 60% लोगों की डेथ घर में हो जाती है। कि यू प्लीज़ टेल अस टू द ऑडियंसेस, टू द मेंबर्स ऑफ द पब्लिक कि हार्ट अटैक के लक्षण क्या होते हैं, क्या टिपिकल होते हैं जो डॉक्टर तिवारी ने बताए और क्या एटिपिकल होते हैं। Now, ladies and gentlemen, I have with me Dr. Vinod Sharma. Dr. Sharma, we see a lot of patients, and Dr. Tiwari has also mentioned, some of them are typical manifestations, some of them are very atypical manifestation. One of our colleague, I'm addressing to, and you know him very well, he was in Defense Colony, a doctor colleague. They were atypical manifestation. I will like that you please tell us to the audiences, to the members of the public, कि हार्ट अटैक के लक्षण क्या होते हैं, क्या टिपिकल होते हैं जो डॉक्टर तिवारी ने बताए और क्या एटिपिकल होते हैं, उसके बारे में जरा बताइए डॉक्टर विनोद शर्मा सर।
Just now Dr. Tiwari mentioned about the symptoms of heart attack, very typical symptoms of heart attack, which most of us have an imagination that there would be a chest pain, it would radiate to the arm, there will be sweating. This is a typical so-called Bollywood type of picture of heart attack, which almost in 30-40% of the people we do not see. They are the atypical symptoms. Some of the atypical symptoms which we commonly see here is that sometimes people feel there is a gas. This is a common manifestation. A average common man perceive any such pain first as a so-called gas. So one is that a type of a sudden onset of flatulence, distension, burning sensation. This is one way of one atypical symptom of heart attack. Another is a suddenly unexplained lethargy, tiredness. Sometimes they just feel shortness of breath, sudden choking sensation. Sometimes people have just felt backache and they mix it with the back pain due to the spine, or I was working for long hours over the computer and they miss the diagnosis. Sometimes they have just pain in the arm, numbness, tingling, which they say probably cervical hai, but it may be a coronary pain. So we have to be alert about any of the symptom which is occurring, especially in and around the chest, especially if it is aggravating on exertion, and if we feel it is a very undue symptom which we have never experienced. So we have to be alert about these atypical symptoms.
I think Dr. Vinod Sharma is a very nice expression that a lot of patients don't come to you and say, I have a heart attack. It's not true. He mentioned a lot of people may come to you with atypical manifestation. We have seen some people come with toothache, intractable, unbearable toothache, and the cause is a heart attack. Some people have unbearable earache and they come to you with a heart attack. And Dr. Sharma has mentioned very nicely, some people may have back pain and they go to a spine doctor and the cause is the heart attack. I think it's very important to understand, a lot of people go to a gastroenterologist, they think it's a gallbladder pain, and it's not true that there's a gallbladder pain. तो हमें समझना चाहिए कि जो हार्ट अटैक है उसके कई फीचर्स टिपिकल होते हैं और कई एटिपिकल होते हैं। और अगर आप डायबिटिक हुए तो हार्ट अटैक साइलेंट भी हो सकता है, दर्द नहीं होगा आपको, सिर्फ सांस चढ़ेगा, कई बार चक्कर आ जाते हैं, कई बार सिर्फ चोकिंग महसूस करते हैं, घुटन महसूस होती है। एंड डॉक्टर शर्मा हैज जस्ट टोल्ड कि यू मे गेट अ सिंकिंग फीलिंग, सेंस ऑफ इम्पेंडिंग डेथ। आई थिंक ये फीलिंग किसी को हो, डॉक्टर शर्मा इज वेरी कैटेगोरिक एंड ही सेड कि हम लोग हमेशा डिनाई करते हैं। फर्स्ट थिंग इज डिनायल, इवन इन मेडिकल फैकल्टी। दिस इज अ वेरी वेरी इंपॉर्टेंट मैसेज। Whenever you have a symptom like this, don't ring up the chemist shop. Don't you call any family physician, just be in touch with a heart line of any nearest hospital जहाँ फैसिलिटी हो एंजियोप्लास्टी की. ये बहुत ज़रूरी एजुकेशन है, इसमें आप सबकी मदद चाहिए जिससे कि आप टाइमली ट्रीटमेंट मिल जाए आपको और हार्ट अटैक से आप वंचित हो सके. अगर डिनाई करेंगे, लेट करेंगे तो 3 घंटे निकल जाएंगे. एंड बी इन टच with a cardiologist. It's very, very important. There should not be any dichotomy or ambiguity in our understanding. Our aim is timely treatment and effective treatment so that we can salvage the jeopardized myocardium. To my extreme right is Dr. J.P. Sani. Dr. Sani, we see a lot of patients with a heart attack. And I'd like to know what are the important risk factors. And I'd like you to highlight on 2 important risk factors. One is the conventional risk factor like dyslipidemia. You are a master and you have spoken on various fields. And number 2, nowadays people talk a lot about the air pollution. And we'd like to know your viewpoints on these 2 important factors in the genesis of heart attack, how it happens, what is that in the cholesterol, which causes the heart attack. Cholesterol is there all the time in the blood, but what is that which is responsible, and how the air pollution is responsible for heart attack. In our expert panel, we have Professor S.C. Manchanda, who has just joined us. He is a big icon in cardiology, known all over the world. He was the first man from All India Institute of Medical Sciences who wrote an article in Indian Heart Journal on yoga and heart. Very eminent personality. Recently he is in Gangaram Hospital. He is a senior consultant cardiologist. Welcome, Dr. Manchanda sir. So I think we'll go ahead with our question to Dr. J.P. Sani on the risk factors. And we are just focusing on 2 important risk factors. One is a conventional risk factor and the second is a new emerging risk factor. Dr. Sani sir.
Yes, for the heart attack, the common traditional risk factors which we all know are smoking, tobacco chewing, high blood pressure, diabetes, lipid disorder, central obesity, stress. These are the traditional risk factors. But the most important risk factor, traditional risk factor I feel, is the lipid disorder, which is the bad cholesterol, LDL cholesterol. Because what happens, all the other risk factors, they push this LDL cholesterol through into the wall of the arteries of the coronary artery, which Dr. Tiwari has already told you. So all risk factors, they push LDL into the wall of the artery, they cause blockages and ultimately leads to angina and heart attack when the plaque ruptures. Now this LDL particle is 20% is coming from the diet, and around 80% it is manufactured or is contributed by the liver, which is largely genetically determined. So the dietary role of cholesterol has become little low these days, but still we should be modest in taking the saturated fat not more than 10% and also restricting the cholesterol diet to that. And that we know the cholesterol is present only in animal product, that is milk, the meats and the egg. So restriction of those diet is also required, but a 10% saturated fat is allowed for general public to take for prevention of, for their normal healthy life. Now what we have found that the emerging risk factor which has been neglected so far has been the air pollution, which we all know now we are facing in our country, and more so in the northern part of the country and particularly Delhi. And the recent data just published has shown that the 16% of the total mortality or death world over globally is because of the pollution. And if you look into that, it comes to approximately 9 million people are dying because of the pollution, which is much more than the tobacco, which is around 7 million. 25% people die of lung cancer, 25 people die of heart attack, 45% because of respiratory illnesses, around 20% because of stroke. Now if you look into the heart diseases and its linked to the pollution, now there is a clear evidence which has come from the observational studies and also the animal experiments that the particulate matters, what we say PM10 and PM2.5, they are very ultra short particles which are there in the pollution beside the other blood gases like carbon, sulfur dioxide, nitrogen dioxide and ozone. All those things, when they enter into the, and we inhale through pollution, it goes into the lung, and through alveoli it enters into the bloodstream. And once it enters into the bloodstream, it causes inflammation of the arterial wall. And that causes the inflammation of the arterial wall, what we say endothelial dysfunction, and also promotes the platelet function, aggregation increases. So all this mechanism ultimately leads to the blockage of the arteries. It results in increased incidence of high blood pressure, diabetes, and also heart failure. Now we have seen that pollution affects the patient vulnerable population, generally those who are elderly or those who are already suffering from heart diseases, or those who are diabetic, they're having renal diseases, they're having heart failure. These are the patients, they are more susceptible to the air pollution, which results in increased cardiovascular death, mortality, and hospitalization. And even arrhythmias are now coming as atrial fibrillation, irregular heartbeat has also been linked to the air pollution. So if you look into this, our air pollution is playing a major role. The upper permissible limit in Europe is 25 microgram per cubic meter, which is the upper limit which has been given. But in USA it is around 10 to 15. But you can see in Delhi we are facing 300 to 400 microgram per cubic millimeter. So yes, and this disease is affecting the low income and middle income countries more than the developed nation. So we have to act now at societal level, at government level, and maybe at personal level to prevent the effect of the air pollution on heart disease.
Ladies and gentlemen, you just heard Dr. J.P. Sani, and he said vulnerable plaque, vulnerable patient, and a vulnerable environment. And he's focusing a lot on the environment. He says that all of us are subjected to the air pollution, especially our children, our grandchildren. They fall victim to a premature heart attack. He also mentioned the mechanisms, whether it's a sulfur dioxide, a nitrous oxide, or various suspended particulate matter. They are responsible to produce a premature heart attack, even the carbon monoxide. So many, even lead, so many chemicals are there which are responsible for a premature heart attack. Is a matter of great concern. He also mentioned that the oxidation of LDL is very important. The trapping, the LDL is low density lipoprotein, is a bad cholesterol which get trapped by the macrophage and get embedded into the inner lining of the arteries and produce a heart attack. And he also mentioned that it may not cause only heart attack, it may cause high blood pressure, air pollution, it may also cause irregular heart rate. Atrial fibrillation is very, very dominant, which is people who are subjected to air pollution. I think it's a very important message by Dr. J.P. Sani.
तीस लाख लोगों को हृदयाघात होता है हर साल इंडिया में। दूसरी चीज़ 20% व्यक्तियों को पता ही नहीं पड़ता और वो फ्लोर पे होते हैं कि यार मुझे हार्ट अटैक हुआ है, मुझे बचाओ तो सही।
To my extreme left is Dr. Ravi Kasliwal. He has done a tremendous work on so-called vascular stiffness. In fact, he was the first man to bring the concept of vascular stiffness by various modalities of investigations. I'll request Dr. Ravi Kasliwal to talk something on vascular stiffness in a premature heart attack and the other conventional risk factors which are responsible, especially in reference to obesity. Ravi.
Thank you. Before I start, let me reiterate three things which Dr. Chopra started this panel with. Number 2, 30 लाख लोगों को हृदयाघात होता है हर साल इंडिया में। दूसरी चीज़ कि हमारे एरिया, हमारे रीजन में कम से कम डेटा है हर 15 मिनट में किसी को हार्ट अटैक होता है। और नंबर 3 चीज़ कि 15-20% व्यक्तियों को पता ही नहीं पड़ता और वो फ्लोर पे होते हैं कि यार मुझे हार्ट अटैक हुआ है, मुझे बचाओ तो सही। If we go with this premise that heart attacks are so common, heart attacks are increasing, people say we are the diabetes capital of the world, but what do these things cause? Heart attacks. And you get, as he reiterated, that you get 1 hour. That is the golden hour. If you do not do anything in golden hour, your heart muscle is damaged, or you are not there to tell the people that I got a heart attack. Coming to the risk factors have already been defined very well by Dr. Sani, and these risk factors interact to cause a heart attack or a stroke or a peripheral vascular disease. How do we define that? How do we come to know कि yes, I am the next person who will get a heart attack? सबसे इम्पॉर्टेंट बात इसमें यह है कि हम लोगों को ये समझना है कि ये प्रिवेंट कर सकते हैं, और ये डिजीज़ है, और ये मेल फीमेल्स दोनों को होती है, और ये 40 साल के नीचे भी होती है, कि 40 साल से कम में भी होती है. जब भी हम हमारे कॉलीग से बात करते हैं अब्रॉड, वो कहते हैं आप 40-35 साल के लोगों में स्टेंट लगा रहे हो, क्या हो रहा है आपके देश में? लेकिन ये रियलिटी है. और अगर आप प्रीमेच्योर कोरोनरी आर्टरी डिजीज़ को नहीं ख़त्म कर पाएंगे तो ये जो एपिडेमिक है ये चलता जाएगा. सो इट्स वेरी इंपॉर्टेंट फॉर अस टू अंडरस्टैंड that yes, it can be prevented. It's not some form of a rapidly acting cancer which you can't control. But are we thinking about it? Do we think that we should exercise? Do we think that what we should eat? And do we ever think that I can go for a preventive checkup? Because we feel that if we go for preventive checkup, somebody will tell us something and we'll have to follow that. एक फैक्ट से मैं चालू करता हूँ कि जो प्रिवेंटिव कार्डियोवैस्कुलर प्रिवेंशन के रूट पे चलते हैं, एक्चुअली 20% उनके कैंसर्स भी कम होते हैं. तो अगर हम उस रास्ते चल रहे हैं तो हृदय रोग से तो बच ही रहे हैं काफ़ी मात्रा में, लेकिन काफ़ी बड़े बड़े कैंसर से भी हम बच रहे हैं. डॉक्टर चोपड़ा ने कहा कि भाई आप कैसे इन चीज़ों को इंटीग्रेट करेंगे. ठीक है, हर चीज़ में एंडोथेलियल डिसफंक्शन हो रहा है, एयर पोल्यूशन अत्यधिक है, डायबिटिक. सबसे पहले आपको डिफाइन करने पड़ेंगे कि आपके हाई रिस्क ग्रुप्स क्या हैं. जो डायबिटीज़ के पेशेंट हैं, जो हाई ब्लड प्रेशर के पेशेंट हैं, जो पोल्यूटेड एरियाज़ में रहते हैं, जिनके फैमिली हिस्ट्री है, उनको नहीं भूलना है हमें, जिनके फैमिली हिस्ट्री है. और देखिए ये बहुत एक ज़रूरी बात है कि फैमिली हिस्ट्री का यही मतलब नहीं कि जिनके पिताजी के हुआ तो जो बच्चे के भी हो जाएगा. जिस फैमिली में हम रहते हैं उसमें शेयर्ड फिजिकल और मेंटल चीज़ें भी साथ चलती हैं. इफ़ द पेरेंट्स आर ईटिंग रॉन्ग, इफ़ द पेरेंट्स डोंट एक्सरसाइज, the children are likely to follow that. So it's the shared experiences of daily life as you grow up. ये चीज़ अकस्मात ही 30 साल की उम्र में नहीं होती, ये चालू तो हो गई 10 साल की उम्र से, ये चालू हो गई ये बर्थ से. तो सबसे इम्पॉर्टेंट चीज़ जो हमें पिकअप करनी है एक प्रिवेंटिव हेल्थ प्रोग्राम में, वो है एंडोथेलियल डिसफंक्शन. जो हमारी आर्टरीज होती हैं, एंडोथेलियम होता है, मीडिया होता है, एडवेंटिशिया होता है, सबसे थिन लेयर जो है, जो कि जो कहते हैं मलमल से भी कई माइक्रोन कम होती है, उसका डिसफंक्शन होता है. और अगर आप एक व्यक्ति की धमनियाँ निकालें तो शायद 3 या 4 टेनिस कोर्ट्स भर जाएंगे, इतना ज़्यादा एंडोथेलियम होता है हमारे शरीर में. और ये कोलेस्ट्रॉल, जैसा कहा गया, कोलेस्ट्रॉल को इनवाइट करता है अंदर आने के लिए, और फिर इंटरमीडियल थिकनेस बढ़ती है. तो हम सबसे पहले प्रिवेंटिव प्रोग्राम जाएँ. हमारे कोई रिस्क फैक्टर्स हो, ना भी रिस्क फैक्टर हो, क्योंकि अगर साउथ एशियन होना ही एक बहुत बड़ा रिस्क फैक्टर है, तो हम जाके अपने डॉक्टर को बोलें भैया मुझे आप चेकअप करिए. वो आपको फिजिकली एग्जामिन करेंगे. आपका बीपी भी अगर 140-90 है तो वो भी एक रिस्क फैक्टर है, जो कि आप वो में इग्नोर कर रहे थे, आपके हेडेक्स को देख ही नहीं रहे थे आप. फिर आपका एक फिजिकल एग्जामिनेशन करेंगे, आपके ब्लड टेस्ट करेंगे जिसमें एलडीएल कोलेस्ट्रॉल की मात्रा बहुत इंपॉर्टेंट है. नॉन एचडीएल कोलेस्ट्रॉल एक चीज़ है जो कि सिंपल एक लिपिड प्रोफाइल से मालूम पड़ती है. और फिर अगर उनको लगेगा कि नहीं ये पेशेंट हाई रिस्क पे हैं, तो डेफिनेटली आपके फ्लो मीडिएटेड वेजोडाइलेटेशन होता है, एफएमडी, जो कि सबसे पहला सबूत देता है कि यार ये इनके हृदयघात होने के ज़्यादा चांसेस हैं. आप ही विल कंडक्ट एन एफएमडी टेस्ट, ही विल डू अ कैरोटिड इंटरमीडियल थिकनेस, जो कि एग्जैक्टली आपको बता देता है कि हाँ एथेरोस्क्लेरोसिस मतलब थिकनिंग और हार्डनिंग चालू हो गई है. जैसा डॉक्टर तिवारी ने कहा कि वो रप्चर होता है प्लाक, उसके बाद हृदयघात होता है, वो पहले ही आपको बता देंगे. अगर कैरोटिड आर्टरी में है, जो धमनियाँ ब्लड ले जाती हैं हृदय से ब्रेन तक, तो ये स्टार्ट तो हो गई आपकी डिजीज़. और उसके बाद स्ट्रेस टेस्ट करेंगे, फंक्शनल टेस्टिंग बहुत इंपॉर्टेंट है. और अल्टीमेटली जो कैल्शियम स्कोरिंग है या कॉर्नरी सीटी एंजियोग्राफी है वो एक अल्टीमेट प्रूफ है कि भैया आपकी धमनियों में, हृदय की धमनियों में एक्चुअली प्लाक बन चुका है। तो प्रिवेंशन के बारे में हमें सोचना चाहिए। प्रिवेंशन, ये डिजीज़ ऐसी है जिसको लार्जली प्रिवेंट किया जा सकता है, ये अपनी सोच है। और मैं फिर रिएटरेट करूंगा कि जो डॉक्टर चोपड़ा ने डेटा दिया ये बहुत ही भयंकर डेटा है। मतलब हर 15 मिनट में हमारे एरिया में किसी के हृदयघात हो रहा है, जो कि हम बचाया जा सकता है। हमने अभी एक स्टडी कंडक्ट करी, हृदयघात 40 साल के उम्र के कम लोगों में, आप बिलीव नहीं करेंगे उस स्टडी करने में कुछ ज़्यादा टाइम ही नहीं लगा। 6 महीने में 120 पेशेंट्स थे जिनके, और उसमें रिस्क फैक्टर्स जो बताए गए हैं अभी, हाई ब्लड प्रेशर, ओबेसिटी, स्मोकिंग, ये यंग लोगों के रिस्क फैक्टर्स हैं। थोड़े जब एल्डर होते हैं तो शायद डायबिटीज़ और स्ट्रेस लाइफ की आती जाती है। दूसरा, स्ट्रेस जो है ज़िंदगी का, इसको अंडररेट मत करिए। हम अपने बच्चों से भी इतना एक्सपेक्ट करते हैं, और 12 किलो के 10 किलो के वज़न कैरी करके 12वीं क्लास का एग्ज़ाम देने जा रहे हैं। पीयर प्रेशर इतना है, अपन लोगों का प्रेशर इतना है। स्ट्रेस को अंडररेट मत करिए, बिकॉज स्ट्रेस आपकी धमनियों को अफेक्ट करता है, एंडोथीलियल डिसफंक्शन करता है, ऑक्सीडाइज्ड कोलेस्ट्रॉल को इनवाइट करता है अंदर। आज का जो लाइफस्टाइल, जीवन शैली की बीमारियां हैं, उसमें मेरा मानना ये है कि स्ट्रेस एक बहुत इंपॉर्टेंट चीज़ है, जो कि कोलेस्ट्रॉल को भी इंक्रीज़ करती है, आपकी धमनियों को भी हार्डन करती है, आर्टीरियल स्टिफनेस करती है, जो कि एक बहुत ही इंपॉर्टेंट चीज़ है, ब्लड प्रेशर तो बढ़ाती ही है। तो इन शॉर्ट ये चीज़ें हैं जो कि हम कर सकते हैं, जिससे कि हार्ट अटैक होने के पहले ही हम बच सकते हैं।
Very important, I think Dr. Ravi Kasliwal has very well highlighted that we are not the world capital of hypertension today, and we are not the world capital of diabetes today. We are also the world capital of heart attack. That too at a young age. The time has come to have an awareness, otherwise it will be too late. Ravi Kasliwal has been a pioneer in working on so-called carotid intermediate thickness. He published a lot of data in Indian Heart Journal. Similarly, the flow-mediated dilatation. And I think a lot of work has been done by it. And it's very clear, this preventive cardiology is the need of the hour. He mentioned that we not only detect the premature risk factors for the heart disease, but also for cancer and other diseases like osteoarthritis, or so many things, liver disorders, so many things can be detected by preventive checkup. His main emphasis was preventive check is the need of the hour after the age of 30 in everybody, including us, including the doctor. We are also human beings. I just give an example. Only yesterday I had a gynecologist, 28-year-old. She has to appear for some exam. And she came with chest discomfort. And she wanted to rule out, क्या उसको कोई हार्ट अटैक तो नहीं हो रहा है? और जब देखा, हार्ट रेट 155. Stress. I think Ravi has mentioned very categorically. It is the stress. Heart attack does not occur in one day. It takes many years to come. That's the message. Cumulative stress, जो कई सालों से, कई दिनों से इकट्ठी हो जाती है और हमारी पूरी बायोकेमिस्ट्री चेंज कर देती है. Liberates lot of epinephrine, norepinephrine, cortisol, जो कि जिटरी मॉलिक्यूल्स हैं, टॉक्सिक मॉलिक्यूल्स हैं. और जितने भी हमारे रिलैक्सेशन मॉलिक्यूल्स होते हैं, जिसे हम हैप्पी मॉलिक्यूल्स कहते हैं, जैसे एंडोर्फिन्स और ओपिएट्स, नेचुरल ओपिएट्स हमारे अंदर होते हैं, उसकी मात्रा कम हो जाती है. और इंस्टेड ऑफ बीइंग हैप्पी वी बिकम ए टॉक्सिक बीइंग. सो हिज मैसेज इज वेरी क्लियर. टॉक्सिक कंजम्पशन, toxic behavior, toxic relationship produce toxicity and make you a victim of a premature heart attack. Ravi, I think it was a very important message. Any patient who has erectile dysfunction should go to a cardiologist now. In what way the heart attack is different in men and women, young and old, diabetic and non-diabetic? see this, how the things start. This was yesterday's news. तो सबको समझना चाहिए कि डायबिटीज़ के अलावा अगर किसी पेशेंट को कोई इरेक्टाइल डिसफंक्शन हो तो ही शुड गो टू ए कार्डियोलॉजिस्ट एंड सी वेयर इज द प्रॉब्लम, व्हाट इज द प्रॉब्लम. टू माय लेफ्ट इज डॉक्टर विवेका कुमार. ही इज ए वेरी एमिनेंट इंटरवेंशनल कार्डियोलॉजिस्ट. Viveka, you do so many interventional procedures for last so many years. I just like to ask you a very simple and straightforward question. And please tell it to the masses. In what way the heart attack is different in men and women, young and old, diabetic and non-diabetic, and the patient population which has got associated significant comorbidities. Just describe, because you have seen the coronaries very clearly, very vividly. So, आपका विचार क्या है इसके बारे में? We want to have your opinion. Dr. Viveka, sir.
Yes, Dr. Chopra. So first of all, let me emphasize the same fact with the other co-panelists have said, is that it's not a disease of elderly population alone. In India, where if you look at the population data, demographic data have suggested that almost 60% or more than that population is in the age group of youth, which is less than 45 years of age. And unfortunately, we are seeing an expanding incidence of acute heart attack. So in younger population, we see that the first presentation is heart attack. That is very unfortunate, and they do not fall in the umbrella what Dr. Kasliwal said of preventive health check. They feel that probably after 40 years or 45 years they would go for preventive health check. So first I would quote a study which is Swedish and Japanese study which was published last week, which said that the aging changes in developing world and specifically in Indians is 20 years earlier. So that study said that at the age of 58 to 60, whatever the changes in vasculatry is there in Indian population is comparable to the changes which is there at the age of 78 in those populations. So you can imagine that it is not just by birth, but it is also because of the environmental factors, so what we eat, what we do, and what stress we have on the society and the pollution, probably everything is cumulative. Coming to the difference in arteries when we treat young people compared to the older people, in younger population, I had last night one patient who was 22 years of age, was son of a councillor in New South Delhi Municipal Corporation, and then that gentleman came with severe chest pain. He couldn't believe that it will be heart attack, but this pain was so severe that he reached to us within 1 hour, and there was when his main artery LED from the origin was 100% occluded. We removed the clot and there was hardly any cholesterol blockage. So we did not have to put stent. It was just sheer thrombus, clot sitting in that. And then we kept on asking the risk factor. The only risk factor was that he was chain smoker. So you can imagine that in an environment, the pollution is equivalent to 15 cigarettes a day for everybody. Then on top of that, if somebody is topping up with smoking, then definitely they are at a higher risk. So in younger population, we don't see much of atherosclerosis. It is clot formation in C2 with a mild blockages or furring of the arteries. Vis-a-vis when we look at the older population, they would have multiple blockages, and one of them has caused 100% occlusion, where you need to prepare the bed, you have to do a good balloon dilatation and then put a stent. So coming to the second presentation is that younger people tolerate the heart attack very well. So that is why they would present to us, after 12 hours, 16 hours, maybe third day, when they get a heart, failure symptoms, breathlessness, and they feel, and even their GPs would encourage them. And very importantly, we have been seeing increasingly more common that the female colleagues, they are getting more heart attack, and that is, the hormones which protect them up to the age, premenopausal age group, is being countered by the other risk factors, stress of work, the stress of, pollution, the smoking is quite prevalent in females now. So I think But despite all these, the presentation in female patient is always atypical, what Dr. Vinod Sharma said, that they would have undue fatigue. They don't really say that I have chest pain. They will feel, they come to and say that, doc, something is going wrong, and I don't think, and they attribute it to, you know, some of the other social pressure or the workload at home or workload at the office. But if you look at, so one of my patients said that, you know, and I take a cue from that, that if you are feeling something terribly abnormal which you have never ever faced in your life, any symptoms above umbilicus and undue fatigue, please get an ECG and get the opinion of a physician who has got cardiology interest, and that should be done at the earliest so that you don't lose the precious time. As you rightly said, Dr. Chopra, that first 3 hours are the golden hours, and then it should be utilized, and earlier you treat, the lesser the heart muscle will be damaged. And the other thing which I have seen paradigm shift in our practice now is the powerful fibrin specific thrombolytic therapies have come. So now we encourage, so initially we used to get called that, look doctor, we are in a peripheral center, we are getting an heart attack, and doctor here has diagnosed, we want to come and it will take at least 2 and 3 hours. Now we say that, okay, get a thrombolytic therapy, fibrin specific tenecteplase injection, and then you come. So now we have moved more in direction of what we call pharmaco-invasive strategy, where we tell the patients that you get the clot busting agent intravenously. We have got our own ambulance services where in, you know, advanced life care support ambulance, these can be given and the health personnel can supervise, but they can get it done in the local hospitals, and then they come. And in our study, where we have studies almost in last 3 years, more than 100 patients, where it has been seen that 30% of patients who received this clot busting agent did not need any stent or anything further. So that's quite revolutionary. I think by this strategy, we can increase the umbrella of effective treatment of heart attack, and it is, you know, if you look at the data, it is as good as primary PTCA. So I think the direction of treatment of heart attack is moving in this direction. And the other thing which is most important and lacking is what we call secondary prophylaxis. So if you look at some person who gets an heart attack, gets effectively treated, goes back to normal life, you should not say that, you know, the chapter is closed. He is more vulnerable, and people stop after 6 months or 1 year. We see that they stop the blood thinners, they stop the cholesterol medicine, statins and all, and they come back with the repeat heart attack. So the emphasis should be that once a heart patient, you are always a heart patient, and you have to have, you know, secondary prophylaxis. If lifestyle modification and the medications are the key, so if that is there, then the second, you know, attack will be lesser. And most importantly, and that is the theme of this panel discussion also, attack the heart attack. And as you rightly said, that unless we involve the population at large, the healthcare givers at large, and the education of the society, that heart attack is a biggest killer on this planet, and especially in this part of the world. And unless the awareness about the symptoms, about the treatment, because this is not one of the disease where you can sit and take 1 month to decide where to go, whom to be treated by. So the availability of immediate diagnosis and treatment has to be there in the community at large, and then only this menace can be countered.
I think it's very important. Dr. Viveka Kumar has given a very clear-cut and lucid distinction between the young hypertensives and elderly hypertensives. One important message is very clear from the example of one of his patients. The people who are smokers, they get only thrombus burden. They don't have plaque. And they get highly effective tenecteplase injection given. The dissolution of the clot is clear and the vessel become very clean. And he mentioned one thing more, 30% of patient may not need even angioplasty. I think the message is very clear. So we have to understand which patient should be given what at what time. I think we are going to discuss in the second component of our discussion. But a very important message is that women have a different mode of presentation. And I think he was focusing and emphasizing on Dr. Vinod Sharma, what he has pointed out. I think this is very, very important, that they are a little different as compared to a men. And he also mentioned that people who come in the elderly age group, they have all kind of comorbidities. Some of them have an underlying occult or overt kidney problem. They may have a lung problem. They may have hypertension, diabetes, and associated comorbidities in the form of cancer, treated with cancer. And he also mentioned that one's heart attack does not mean you uprooted the disease. You have to have an awareness for prevention of a second heart attack, and we should not leave the medicines because they are also vulnerable. He has all those kind of patients who come to us, who come to him, attack after heart attack. So I think it's very important, those messages should be known to each and every one of you.
I think one of the simple explanation is it is a lifestyle related disease. We all know that these are lifestyle related diseases. What is lifestyle? Lifestyle means
Ladies and gentlemen, it's a great privilege for me to introduce our new expert here who just joined us, Dr. N.N. Khanna, who is the senior interventional cardiologist and the coordinator of cardiology, cath lab and vascular services at Indraprastha Hospital, Apollo Hospital in Delhi. Welcome, sir. Now I request Dr. Manchanda, who is here with us, who is a very eminent person. I call him as a guru of yoga. I don't know whether he believes my statement or not, but he is a guru. And he, as a person who did a lot of work on the mind intervention, he believes that most of the problems are caused by ourselves, by our choice making. Let's see what Dr. Manchanda has to say, the role of mind in the prevention of heart attacks and creating a healthy heart, including yoga. Dr. Manchanda, sir.
Thank you. Well, as you heard, there are several risk factors for heart disease. Psychosocial stress is one of them, and this has been a neglected factor for a long period of time. You also heard that there has been a lot of advancement in the awareness about the heart attack. People are aware that they have to do exercise, they have to avoid tobacco, they have to take proper food, etc. But in spite of all the advances like angioplasty, bypass surgery, even heart transplants, the heart disease is increasing. Have we ever introspected? Well, I think one of the simple explanation is it is a lifestyle related disease. We all know that these are lifestyle related diseases. What is lifestyle? Lifestyle means the behavior of an individual in which the mind interacts quite a lot. For example, it's a mind-body interaction. Mind creates thoughts. If my thought is not to do exercise, I will not do it. I ask some of my patients who are very well educated, why don't you exercise? He says, doctor, I get up in the morning, I want to go for a walk, but my mind says, don't go today, go tomorrow. And tomorrow another excuse is there. I go to a party and my mind says, have this bad food, but don't have tomorrow. Tomorrow is another excuse. So it is the weakness of the mind which is causing it. Even one of my patients who knows so much about smoking, he says, my mind says 1 or 2 cigarettes does not matter. And then he doesn't know where this really ends and all that. So mind has a very strong effect on the heart, and this is called mind-heart relationship. As you know, as is the mind, so is the body, and for a long time we know that if healthy mind has a healthy body and a healthy body. So I think we have failed in tackling this problem because we have forgotten the relationship of mind. And the mind can be stabilized by our ancient technique called yoga. Yoga is not a few asanas only, it's a complete way of life in which we remain physically, mentally, emotionally and spiritually healthy. For example, diet is a part of yoga, sattvic diet, which you heard about. That's a way to prevent heart disease. Not taking tobacco is also a part of yoga. Then stress management is a very important part of yoga. And the most important thing is that the mind becomes strong. For example, I have been treating patients with yoga and even young people, and these people have their mind strong. So when they want to exercise, they'll get up in the morning. If the mind says, don't go today, they will say, you shut up, I will go it. And the mind has to be strong. And it has a lot of studies are there that yoga can prevent heart disease. All the risk factors that you heard high blood pressure, for example, large number of more than 1,000 studies are there that blood pressure can be significantly lowered, diabetes can be lowered, psychosocial stress can be lowered, smoking can be stopped with this. There are a lot of studies for this, and even the cholesterol could be affected. And there's a lot of data now accumulating, especially in the animals, that these risk factors like anger, ego, hostility, jealousy, they can cause heart attack. You must have heard of some people suddenly getting angry and they get a heart attack and all that thing. And a lot of studies are there which shows that these psychosocial factors, even poor socioeconomic status, even a bad neighborhood, etc., even the pollution you heard, not only the pollution of the air, but even the sound pollution. There's a big study which came, people staying next to the highways. So stress is a big factor, and this stress can be controlled by yoga, and that is a mind-body relationship. And therefore, I suggest that all people should be doing yoga. There are some studies to show that people who are happy, this means they are doing yoga, because the ultimate aim of yoga is to keep you happy and stress-free. People who are happy, they have less heart attacks. People who are under stress, large number of studies are there, stressful jobs, they get this heart disease. And in the animals, it has been shown, even if you give very low fat diet and produce anger in them, they get heart disease. On the other hand, you give very high cholesterol diet and the animals are given some compassion, love, and the heart disease can be prevented. So the role of these emotions in the heart disease is still to come, but there are a large number of clinical observations that these bad emotions can also cause this heart disease. So I believe that the mind has a strong relationship with the causation of the heart disease, and if we can control the mind, which we can by our ancient technique of yoga, the heart disease could significantly decrease. And there are studies not only before heart attack, even after heart attack. A large paper was presented recently in the American Heart Association in Chicago, in which more than 4,000 people who had heart attack and angioplasty, when they were trained in yoga, they had a better outcome than those people who did not have yoga. So yoga has a tremendous potentiality. It started in our country, and I think we should be following in our patients.
I think Professor Manchanda has given a very clear message. Heart attack is born in the mind, manifest in the heart. Very important message. If you conceive the thoughts, perceptions, interpretations, experiences, and choices of toxicity, you will get a premature heart attack. And he also mentioned, if you get the perception, conception, and thoughts and interpretations of love and compassion and humility, you will get a healthy heart. Very beautiful expression, sir. I think you mentioned that just one fit of anger can produce a massive heart attack and even a sudden death. And you and me as a human being have only two emotions. One is the emotion of fear. It is from fear originates jealousy, hatredness, anger, hostility, cynical behavior. And then we have vengeance, vindictiveness, suppression, frustration, depression, repression. Everything is an offshoot of fear. And on the contrary, Dr. Manchanda has mentioned that you must have a perfect mindset. If you have a perfect mindset, you are going to nurture 60 trillions of your cells with 60 trillion chemical reactions occurring every day in the body with love, compassion, altruism, and empathy and sympathy, and you will be in the parasympathetic mode all the time. A very beautiful message. You should not be in a sympathetic mode, in an aggressive mode, all the time vulnerable. You have to be non-vulnerable from childhood to remain non-vulnerable till the age of 80. After 80 is a God's will. We all have to go. We are not permanent in this universe. I think that's a very important message. And his message is very clear that mind and heart has a very strong connection. That's a very important message. Thank you, sir. I think it was a very, very nice expression. We have with us Dr. Anand Khanna. He does a lot of intervention. Dr. Khanna, I have just a very important question to you. You do a lot of coronary intervention, peripheral vascular intervention, carotid interventions. What's your impression in your practice today when you see heart attack patients? Are they young, or they are old, or they are same what you were seeing 20 years ago? Or you find there's a difference in the practice today? Dr. Khanna, sir.
If you see patients in my last 25 years of practice, not only that earlier we were seeing patients who are younger than their Western counterparts, but now the age has really come down to late teens, 19, 20, 21, and it goes up to 35. In fact, we analyzed the data in our hospital for last 2 years. We found that 20% of the patients are below 30 years of age who come with acute heart attack. And many of these patients, when we see their coronary arteries on angiogram, they do not have multiple blockages in multiple arteries. It's only one plug which has ruptured and created a devastating effect on the heart, and the heart is really weak and they suffer throughout their life or they die because of it. And I'll come back to this. The risk factors would usually are smoking, a very poor lifestyle which they have adapted, gone back from our Indian way of lifestyle to a Western style. And what Dr. Manchanda said, the stress, extreme competitiveness, lack of sleep and jealousy, negative emotions, those are usually the trigger points for acute heart attack in young people. And these are, they create a devastating effect. So this is one thing which is very peculiar in our country, which we are seeing as a trend. And therefore, the focus should be to reverse this or to prevent this. And what is required is sort of a proper conditioning of the mind, proper habits, in terms of exercise, in terms of yoga, in terms of taking control of their diet, and also checking their lipids. That's another thing which has come up recently, that they have very bad lipid profile. Their good cholesterol is really low, the bad cholesterol is high. And these patients are usually sedentary, they are not very active people. So this is one reason of acute heart attacks in young people. The other group which is very surprising, which is coming of late now, is young enthusiasts who gym a lot. They take all sort of hormones and testosterone boosters. They have very artificial lifestyles and they are into muscle building abnormally. These patients also tend to come to us with acute heart attacks while gymming or while having a very aggressive lifestyle. So these are the two things which we have found in recent studies.
So I think our three experts, including Dr. Manchanda, Ravi Kasliwal and N. Khanna, are of the same opinion. And their opinion is very straight, that all youngsters are very enthusiastic, highly ambitious, and have a negative competition. And that's how they fall victim to oxidative stress and fall victim to a heart attack. I think Ravi has also mentioned that stress scoring is very important in preventive health programs. So I think a time has come, we have to create so-called happiness classes in the schools. I think Delhi government has already started this kind of program. So I think in winter, it is seen that there is a little peak and increase in the heart attacks because there is a tendency for clotting more as compared to summer. And hypertension also is very, very common in the winter. Stroke rate, even I've seen a lot of sudden deaths more common in winter. So maybe by this we will be able to combat the various risk factors to a very large extent. And I always believe a very nice statement which me and Dr. Manchanda has shared on various platforms. And that is, if you have a kindness in words, it creates confidence. Kindness in thinking creates profoundness. Kindness in giving creates love. And kindness in loving creates happiness and a healthy heart. Love is free. There is no cost, but I don't know where do we keep it. It's not expensive at all. But why don't we share and care? It's a matter of concern. I think Dr. Manchanda was very categorical. He's a hero, I think. And he mentioned that make your mindset robust and perfect if you want to have a healthy heart. I think that's a very important message to prevent the heart attack. I think beautifully expressed by everyone, every expert panel, that we have to prevent heart attack. That is the main agenda. If you take Indian scenario, we see a lot of heart attacks in southern part of India and the risk factors are different. And a lot of heart attacks we see in northern part of India where the prevalent factors are different. Just two examples. Say, for example, a lot of studies have been done, huge data, and we find if we make a zonal expression from south zone, east, west, and north, in northern side, the dietary factors are very, very important. People consume wrong food at the wrong time, in the wrong place, in the wrong dose, in the wrong environment. And some of the factors in south are different. We consume different kind of oils, and they are having a different factors. But stress is dominant factor everywhere, whether it's a northern part or the eastern part or western part. There are various factors. When we say heart attack, it is not one factorial, it's a multifactorial. Some places factors are dominant. You take Chennai, for example, the diabetic prevalence is very high. If you take Punjab or Tamil Nadu, diabetes is very high. So there are different risk factors at different places. But if you take the overall picture, I think most of the risk factors are same. The only difference is at some places, some factors are more and some factors are less. But we must make sure that we create a balance in all the risk factors. And moderation is the key in our exercise protocols, in our thinking process. Dr. Manchanda was very specific that I plan to exercise, but my other mind says, no exercise today, you have to go for a walk. So I think we all need to set our mind. If we set our mind, the risk factors, single factorial or multifactorial, can be taken care of. That's a real message from our panel. In winter, the prevalence of heart attack is to a higher extent. The reason is very clear, because we are highly vulnerable to get a shoot of high blood pressure, and then we have sedentary lifestyle, and we have a peripheral vasoconstriction as well as the constriction in the arteries, narrowing of the arteries, and we eat the diet which we don't eat throughout the year. We eat a lot of gajar ka halwa, and we don't exercise. You know why we eat? Because we have poor mindset. We don't know what we are doing. We are abusing our body. So I think in winter, it is seen that there is a little peak and increase in the heart attacks, because there is a tendency for clotting more as compared to summer. There's a little difference in the winter. I agree with you. And hypertension also is very, very common in the winter. The stroke rate, even I've seen a lot of sudden deaths more common in winter. Dr. Sani, any opinion?
The two important factors. One is the temperature varies from 1 degree in winter to 45 degrees in summer. This is not seen in the southern part or in the tropical area like Mumbai and Goa, and where it's 20 to 40 degrees. We did a study on that, as Dr. Chopra rightly said, about the blood pressure part, and we started looking into the causes. We found approximately 50% or 60 or 100% increase in doses of the antihypertensive drug is required in winter compared to the in the summer months. And the reason which he has already said, there is a loss of sweating, so the salt remain inside, water loss is not there, blood vessels constrict, vitamin D is low, pollution is there, and our festivals are also very high. We exercise less, we smoke more, we drink more. All those factors leads to increase in the risk factors, particularly the diabetes and hypertension, and also the platelet aggregation becomes more. So they result in increased heart attack, heart failure, kidney failure, everything comes in the winter. And vice versa is true during summer. When we sweat, there is a water loss, there is salt loss, we exercise, and the blood pressure becomes a little lower. So that is very,
It's the extremes of weather, extreme cold and extreme hot. They are all responsible. Vinod, what is your opinion? I think Dr. Sani just mentioned about vitamin D. Do you think the reduction of vitamin D, deficiency or insufficiency of vitamin D, make us more vulnerable to stroke and heart attacks and high blood pressure? Vinod?
It makes vitamin D is emerging as one of the important risk factor for occurrence of a vascular disease, whether it is a heart attack or a stroke. And as a part of the preventive assessment, most of the program incorporate the assessment of vitamin D, and we should be aware of that this is one of the important, it has an important role. Now, just mention about this prevalence in the different part of the country. I haven't come across a very organized data, but what we have been seeing that, and I see in my native state in Chhattisgarh and the central India, if we see that part of the country, one peculiar trend I have noted, and the medical college of Raipur is studying this pattern. One is that if we see the central Indian population, their smoking prevalence is very high. Like North India, diet is the playing role, South it is probably diabetes is playing role, Central India is smoking prevalence is very, very high, including among the women. Now second is that we have noted there, even in the summer, like in Delhi or in North India, we see the surge of the patients with the heart attack and sudden death coming in the winter month, but there they have found equal number of patients getting admitted in the summer, because that is the June. In fact, this United Nations has declared that the Central India is going to face a heat crunch, and that population is suffering from a kind of a heat crunch, and many of these patients, I have performed procedure there, they have just like as Viveka mentioned, just a thrombus. In the peak of summer they have come with heart attack and it was just a thrombus, nothing else. So that factor need to be studied further and it has definitely a role.
I think Vinod Sharma and Dr. J.P. Sahni has given a very important point, that the extremes of weather. Dr. Vinod Sharma has said in Chhattisgarh area where there is extreme heat, in extreme heat, when there is a heat stroke, they may have a cardiac stroke also, and the cause is again a thrombus. Sir, Dr. Manchanda, you want to say something?
Variation of the heart attacks are very well known. Early morning, between 6 to 8 o'clock, especially Monday morning, the Western countries, the catecholamine surge is very high. So we suggest people should try to decrease it by doing yoga. Yoga was classically done and it can decrease the catecholamine. So it is very well known that early morning is the worst period before you go to the office. Another bad thing which can occur, you see, we had when we had the maximum pollution in our country, this was true in China also, the heart attacks increased. And the third factor could be fear. You know, there was an earthquake in Los Angeles and the heart attacks increased in that region for the next 1 year. There was a terrorism attack and the whole population is affected. This psychosocial factor, these are very well documented. After 9/11 in the United States, the heart attacks in New York increased. So any psychosocial factors acutely can also affect it, but the seasonal variation and other things are very, very important.
Some people come in time, some people come quite late, their heart is damaged, and some are already brought in dead, having a sudden heart attack, and they are brought in the ambulance, and you do resuscitation, and nothing is there. What do you think is an important thing we should do? I'd like to ask him, Vinod, we see so many heart attack patients in your center who comes to you in the ambulance, right in your vicinity. Some people come in time, some people come quite late, their heart is damaged, and some are already brought in dead, having a sudden heart attack, and they are brought in the ambulance, and you do resuscitation, and nothing is there. What do you think is an important thing we should do? Because if you see the data from Indian registry data, which I was very actively involved, and I published in Indian Heart Journal somewhere in 2009 on clot lysis or thrombolysis. Full issue was published. And I worked in United States almost for 4 years in UCLA. And I used to go on a helicopter in a blue coat team. And I used to give TPA, those days called TPA, tissue plasminogen activator, right on the roadside, or right in the office to the patients. And the patient are lifted in the helicopter in USA and straight away taken to the cath lab. What's your opinion? Italian registry published recently, Indian registry almost of 5,000 patients published from all parts of the India, and the data is very clear, because the success rate reported by 10 eclipse plays is up to tune of 96.6%. And they say we adjust the dose half of the weight of the patient, and in elderly beyond 75 we give half the dose, and it's very safe, effective, and very, very sensitive, and has got a huge impact, like Viveka was mentioning, especially in young who are having a heart attack and who are smokers. We'd like to have your opinion. What is the message for the public you would like to give in the pre-hospital management of heart attack, hospital management of heart attack? Just two important components. I'd like to have your opinion. Dr. Vinod Sharma, sir.
See, we have to understand one very basic fact about the heart attack. Heart attack is a sudden, instantaneous, total occlusion of a coronary artery with so-called fibrin-rich clot. And our objective should be to open this artery as quick as possible. Time is muscles. We all discuss here. As the time from the onset of the heart attack passes, we are damaging more and more heart muscles. Heart muscle is life. So we have to achieve so-called reperfusion, means opening of the artery as early as possible, as complete as possible. Now we have modalities. We have clot dissolving drug, as you mentioned, tissue plasminogen activator, that variants are there now with a good efficacy, almost 90% plus. And there are studies, some of the studies you quoted, even the pre-hospital thrombolysis, well before patient arrives the hospital, even at clinic, on the ambulance, if you use this drug, you save heart muscle. So our objective should be that we should achieve reperfusion as soon as possible. Mode of reperfusion, whether you achieve by clot dissolving drug or by angioplasty, that is not important. If somebody has reached hospital in a working time and everybody is ready with the cath lab and it is operational, and within 90 minutes if you can open artery, nothing like that. But if it is in a remote location, in a place from where a person will take at least an hour and a half to reach to a center where primary angioplasty can be performed, it is good to use this thrombolytic drug, because on-site thrombolysis is better than off-site primary angioplasty. Our objective should be to achieve perfusion, that is the opening of the artery, and the current generation of thrombolytic drugs have achieved the best possible result.
Thank you very much, Ajay Vinod. I think your message is very clear. I was recently in Cochin in EpiCon, and I was very impressed by the talk given by Professor Balram Bhargav, who is the Director General of ICMR, and he's shown the whole data from All India Institute of Medical Sciences, Mission Delhi. It's not Delhi, it is Delhi. E stands for emergency, L for life saving, H for heart attack initiative. I thought it's a Mission Delhi. I'm talking only of Delhi, not of India. But the mission is very different. There are 11 members in the team, and he's shown a beautiful data. He is the first man in northern India to start pre-hospital thrombolysis based on the data collected over the last 35 to 40 years. And I think it's a revolution. They've started some motorcycles, and motorcycles, people go there, go at the FMC. FMC means at the site where a person had a heart attack, first medical contact, and they go there and straight away they take an ECG. ECG is being transported to the heart center, and a cardiologist see the ECG, not a non-cardiologist, and say yes, he has a heart attack. He also discusses the symptoms what patient had, and once it is a heart attack, he says, okay, give a clot dissolving injection. Clot dissolving injection can be given by anybody. There is no medical legal hassle, but it has to be under supervision of a doctor, under supervision of a cardiologist. Even a GP has to do under supervision of a cardiologist. So heart station is important. Under the control it should be done. Remote can be done to salvage the life, but under the supervision. And then in an ambulance, they should shift the patient to the nearest hospital to go for PCI. Percutaneous intervention is a must for every patient who had given teniectic place. So I think it's very important, and Dr. Vinod has mentioned very nice statement that longer distance you are, teniectic place is superior. The shorter distance you are, primary PCI is better. I totally agree with him. If you reach in time, there is no doubt that the gold standard is primary PCI. We agree with it. But since 90% of patients, it is not accessible, that's how they go. Pre-hospital clot lysis followed by angioplasty. What do you say, Viveka sir? I'll ask Dr. Viveka Kumar, what's your opinion, sir? So you're running a program on a heart attack. What is your recommendation? You got the services. What kind of network we should create in Delhi so that we can approach to government and we can approach to non-government organizations like they are doing in South. They are very active in South and they have a very nice network and very good care. They provide to all the patients. Most of them receive thrombolytic agents before they reach the hospital. I like to have your clear message as Vinod is given, pre-hospital clot lysis followed by angioplasty. What do you say, Viveka sir?
Yeah, so I think as we know that heart attack is an epidemic and we need to have best possible penetration. So eventually it is the end user, that is in this case are the people who are affected by heart attack. They should be brought to the umbrella of best possible treatment to decrease the mortality. And it can only be done when every first medical contact point, so be it a primary healthcare, be it a clinician's own clinic, everywhere the facility should be linked, that the ECG should be read or should be opined by a cardiologist. So we need to have that kind of network, and looking at the distance and the cost effective, because unless the treatment is easy, safe and cost effective, that is not going to be implemented easily. So we are a nation which is resource starved, so we need to use our resources very carefully. So the easiest thing which comes to my mind and has been replicated in some part of the world as well, if you look at the Prague registry, there it was very well regulated that you don't have to create an open cath lab in every center. You need to link them. You need to, and pharmacoinvasive data is so robust, and then the beauty of that is that almost 30% of them would not need any further revascularization. So I would say that all first medical contact points where an ECG can be done should be immediately reported, and then it should be trials to fibrin specific thrombolysis followed by the pharmacoinvasive strategy where the angiography can be done. It would take lot of effort, but a concerted effort, because we are doing it in North India as silos. We are just not coordinating between. So I think the government initiative has to be there, that if it is an heart attack, it should be nearest capable center and it should be interlinked so that we can give the best possible treatment to our patients, because it's more important for Delhi because our traffic is so bad that if somebody wants to go to from one zone to next zone, probably the golden period will be lost. And then the power of pharmacoinvasive therapy has to be looked at, because if you see that within 3 hours, if they are thrombolized, as Dr. Vinod Sharma said, then apparently the cost of cath lab and all those things is we can save that. And then given the amount of disease burden, we should reserve the early invasive treatment in people who do not have, who have failed thrombolysis, who have got cardiogenic shock and all those kind of things. So I think the educating the society and the education should go right from the schools, where the early recognition of, if you look at the data that patients who have come from a family where heart disease is there, they reach hospital far earlier than where the families who are, even if they have, richest of the rich people, if the education of heart attack and symptoms is not there, they come quite late. So I think the education should be right from the school, it should not only be taught in medical schools, but in the general schools also. And then the communication and linking all the health facilities together should be the priority.
I think it's very important, Dr. Viveka mentioned very important, that the realization of pre-hospital thrombolysis has come in North India now. In South India, it's existing for last many years. Worldwide, in United States or Europe, whole data is coming from there, whether it's a stream data or other trials like I mentioned to you, Italian registry data is very, very clear. And they are implementing as a routine that pre-hospital thrombolysis is the answer if you really want to salvage the jeopardized myocardium, because 90% of them cannot reach the hospital. The same thing is expressed by Viveka, that we must impart education, and this is the best media. I am very happy that FAM Health, Tata Sky FAM Health has taken this initiative, and I'm sure this communication will be perceived by almost 1 crore people. And they promised me that they will show it at least 48 times in a year. That means every week they will show us this program. So that there is a massive awareness, education in the people's mind how to attack heart attack, and they know what the symptoms are, so they go to a right person at a right time in a right place, and they don't go to a small nursing home or to a small center where the facilities are not there. Ultimately, all the patient has to land up in a hospital which has PCI capable. I think I'd like to ask Satyen Tiwari. We see sometimes patient had a heart attack, they had a stent, they had a PCI. Still, if they get chest pain and they get a second heart attack, what should they do?
Yeah, that's a very important and good question, because we do see patients who have already have a blocked arteries. It is immaterial whether it is opened by a drug or some procedure has been done. So the important thing is the early recognition by the physician, and then transport to a place where the facilities are there. So all these patients who have already undergone some procedures and already have a blocked arteries, so they should ideally have a proper treatment charting. They should have a card with them all the time while they are traveling. So they should know, the doctor should know what the drugs they are on and what are the places nearby from their residence that they should go if the symptoms or something has happened. So these are the patients should be registered and enrolled to the nearby places where they work or they reside. So that's very important for such populations.
So I think it's very important that whenever there is a chest pain, please be in touch with a cardiac center. Under the supervision and guidance of a cardiologist, the instructions will be given. People are using tele-EKG, they're using tele-echocardiography, tele-cath, tele-radiology. Whole world is changing. Recently in Gujarat, we heard that even tele-angioplasty was done. By a remote area, angioplasty was done. People are using robot, artificial intelligence. Digital media is playing a very, very important role. I am working on thrombolysis for the last 36 years. And I am totally convinced by the experimental model, by observational data, randomized data, meta-analysis, and a huge registry data, that it works very effectively, but none of our patients should be without a PCI. That's a very important message. So they complement. Ravi Kasliwal is doing a conference, I think on 13th or 14th, and he wanted me to speak only on pharmacoinvasive. Would you please highlight what exactly you mean by pharmacoinvasive for the common man?
Yeah, that's a good question. The pharmacoinvasive, as you have said, that those who can reach a hospital within an hour or so, they get a primary angioplasty. But those who are remote, and yet you do not want their heart muscles to be damaged, obviously, because if the heart muscle is damaged, he will be in the ravages of heart failure for entire life. So in those individuals where it is not available, you give the pharmacological drug, tenecteplase, or such what drugs that we call clot busters. Do not deny them the use of tenecteplase, as has been repeatedly said by every panel member, that a chest pain with ECG characteristic of a heart attack, don't deny them. It can be given in a good adequate facility under the care of a cardiologist. Once you have given the pharmacological route, at least you have been able to stabilize the patient, that if you think, and when the time is appropriate, you can then shift him to a center where all other facilities are available. They can have a good echocardiography, they can go to the cath lab if so required. And as has been said, you have also taken care of cardiogenic shock. Many of them would have gone into a cardiogenic shock with a proximal left anterior descending artery block. 30% of the heart muscle would have gone in 5 minutes. So truly here you have come with this dictum that there is something called the golden hour. You are sitting outside somewhere, like we have done at Medanta. What we have done is that some of our people who were fellows in our institute and are now located 5 to 10 kilometers away, they, on an iPad, they send us their ECGs of patients with chest pain. And we talk to them immediately. This is in the heart command center, that look, this is a heart attack. Whether the patient can afford or not afford is a secondary issue. But if the transport facilities are taking time, at least give them a clot buster drug. And that has saved many lives. Even if you reach the Medanta emergency room, you will not be taken into the heart command immediately. There is no need. In the triage, we have a chest pain unit. And if there is clearly ST elevation, then there is no need to go anywhere else. But whichever route you want to go, you can do it. Our door to balloon time is really quite less, and we can open up the arteries because, as has been said by every panel member, an open artery will salvage myocardium immediately. So I think pharmaco-invasive route is the way to go in India, both from the point of view of remoteness and also from the point of view of the chaotic traffic and the recognition. Sometimes the ECG may not be abnormal the first time the patient comes. The ECG becomes abnormal only after 1.5 hours or 2 hours when you do the second ECG, and then the troponins also increase. So I think in today's day and age, I think Dr. Chopra's work on this approach, which he will also highlight in our own meeting, makes a lot of sense. Just do not think a heart attack is equal to angioplasty, which can actually save a person. As somebody was saying, our people do it in the ambulance itself. So I think you've touched a very, very important point.
So very important message given by Dr. Ravi Kasliwal. Everyone, member of public, should know what a clot buster is. He also mentioned sometimes there may not be any classical EKG changes. So you may abort heart attack. You can make a large infarct to a smaller infarct, a transmural to a subendocardial infarct. You can also prevent the extension of infarct. And he also mentioned that you can prevent the cardiogenic shock. So it's very safe. The only thing is it has to be under the supervision of a cardiologist. He also mentioned that they have a chest pain specified beds in the heart command center, and we take a decision where to do what. If the cath lab is very busy, they straight away go for tenective place because no harm is created, it's only benefit. I think it's a very nice message, Ravi. Dr. Khanna, you see patients coming to you after 6 hours, they don't come in 3 hours. What do you think is the role of tenective place there? Should we not? Or let the patient suffer or die, or let him have more damage and your cath lab is too busy? What are you going to do? Dr. Khanna, you see patients coming to you after 6 hours, they don't come in 3 hours. What do you think is the role of tenective place there? Should we not? Or let the patient suffer or die, or let him have more damage and your cath lab is too busy? What are you going to do? What is your message?
It's like one has to see if the patient comes with a chest pain, say maybe even 6 hours after the MI, one has to understand that still there is a viable muscle. So if the chest pain is continuing and the ECG is showing definite ST elevation, definitely if the patient cannot be taken to the cath lab, I would ideally like to take this patient immediately in the cath lab. If he cannot be taken in the cath lab, then we would give tenective place, wait when the lab is free, again do an angio and see what's happening. But we should definitely not deny these patients the advantage of tenective place. And if the patient, especially if he is having pain, that means the muscles are crying with lack of oxygen, they are still alive, they need to be revived and salvaged as early as possible. So that's a very clear message.
So I think public के लिए message बड़ा clear है और डॉक्टर NN खन्ना ने बड़ा स्पष्ट रूप में समझाया कि अगर किसी पेशेंट का पेन कंटिन्यूअस है, इसका मतलब हार्ट रो रहा है, हार्ट क्राई कर रहा है कि वो वायबल है. पेन इटसेल्फ इज ए क्राइटेरिया ऑफ रिवर्सिबल रिपरफ्यूजन. अगर उसको हम tenective प्लेस देंगे तो उसका हार्ट अटैक काफ़ी हद तक सेल्वेज कर सकते हैं. वेरी नाइस मैसेज. इफ द पेन इटसेल्फ इज ए क्राइटेरिया ऑफ रिपरफ्यूजन. इफ देयर इज नो पेन मीन्स मसल इज डेड. So I think वो समझना चाहिए. That's why I say every time, every patient should be under the observation of cardiologist. Just a last comment now by our eminent, a very experienced cardiologist from All India Institute, Professor Manchanda sir. Your opinion?
I think public can help us in attacking the heart attack also if we teach them CPR. You see, the cause of death in the first hour is cardiac arrest. And every citizen, I would suggest, even school children, should learn how to do CPR. It's a very, very simple technique, pressing the chest, and you can save large number. I think by this simple technique, you can save more lives than doing all those interventions that we are thinking of. If the patient is not alive, we can't do anything. Sometimes what happens is after giving this extremely good thrombolytic therapy, the patient goes into cardiac arrest. And every citizen, I think, should learn this. And if the citizens, school children know how to do CPR, which is very, very simple, I think they can help us in attacking the heart attack.
So there are two important things, ladies and gentlemen, which we should not have a confusion. One is a heart attack, second is a sudden cardiac death. They are two different things. ये इसके बारे में जानकारी होना बहुत ज़रूरी है. हमने जो डिस्कशन किया वो हार्ट अटैक के बारे में किया कि किसी को पेन हो या एक्सट्रीम स्वेटिंग हो या बहुत थकावट हो या चक्कर आ जाए या गिर पड़े या चोकिंग सेंसेशन हो और ईसीजी में अगर एविडेंस है कि हार्ट अटैक है तो आंसर इज फर्स्ट टेनिक प्लेस एंड देन एंजियोप्लास्टी. अगर एंजियोप्लास्टी सेंटर दूर है तो, और अगर एंजियोप्लास्टी सेंटर पास है तो फर्स्ट एंजियोप्लास्टी, नो टेनिक प्लेस. द मैसेज इज वेरी क्लियर. डॉक्टर मनचंदा ने एक बात और कही कि अगर किसी को सडन कार्डियक डेथ हो जाए तो हमको देखना है कि वो पेशेंट जीवित है या उसकी डेथ हो चुकी है. उसके हम साइन देखते हैं. हम अपना हाथ उसके फेस के सामने रखते हैं या नाक के सामने रखते हैं कि वो ब्रीदिंग कर रहा है कि नहीं. नंबर 2, हम देखते हैं ये जो नाड़ी जो रवि काचलेवाल कह रहे थे कैरोटिड आर्टरी, वहाँ फील करते हैं कि नस पल्सेस है कि नहीं. और फिर उनका हम चेस्ट का मूवमेंट देखते हैं कि ब्रीदिंग है कि नहीं. अगर ये नहीं है मतलब उसकी मृत्यु हो चुकी है. अगर मृत्यु हो चुकी है तो मृत्यु भी 2 टाइप की होती है, टेम्पररी डेथ और परमानेंट डेथ. तो परमानेंट और टेम्पररी के कन्फ्यूजन में नहीं रहना है. जो डॉक्टर मनचंदा ने कहा आपको CPR करना है. CPR मतलब कार्डियो पल्मोनरी रिससिटेशन. कार्डियो मतलब हार्ट, पल्मोनरी मतलब लंग, रिससिटेशन मीन्स पुनर्जीवित करना. इसकी विधि सबको आना चाहिए. अमेरिका में तो आप स्कूल में हो तो वहाँ भी सिखाया जाता है. आपको स्कूल का सर्टिफिकेट नहीं मिलता अगर ये सर्टिफिकेट नहीं है आपके पास. सीधा अवेयरनेस. ये अमेरिकन हार्ट एसोसिएशन और अमेरिकन कॉलेज कार्डियोलॉजी की रिकमेंडेशन है. डॉक्टर मनचंदा ने जो कहा हम चाहते हैं CSI को भी वो करना चाहिए, API को भी करना चाहिए, हर एक काम में करना चाहिए. CPR की ट्रेनिंग हमारे घर में हमारे बुज़ुर्ग लोग होते हैं जो डायबिटिक होते हैं, जिनको सडन डेथ हो जाती है, उनको पेन होता ही नहीं है, तो उनको कैसे करना चाहिए जानकारी मालूम होना चाहिए. इट्स वेरी नाइस एक्सप्रेशन डॉक्टर मनचंदा. सडन कार्डियक डेथ एंटिटी के बारे में पता होना चाहिए, हार्ट अटैक के बारे में पता होना चाहिए. आई एम वेरी ग्रेटफुल टू ऑल द पीपल हु आर सिटिंग हियर एंड हु हैव गिवन ए ब्यूटीफुल वर्ड्स ऑफ देयर विजडम ऑन द मैनेजमेंट ऑफ हार्ट अटैक at the first medical contact. The next question is, after the heart attack, what should we do? We have with us Dr. J.P. Sani, who has done a lot of work on so-called cardiac rehabilitation. पहले तो मेरा विचार यही है कि जब भी किसी को हार्ट अटैक हो, चाहे टेनिक प्लेस हो या एंजियोप्लास्टी हो, please go to your respective cardiologist, and I feel there should be a nice rehabilitation program. जिससे कि उसको फिर से हार्ट अटैक ना हो, उसके रिस्क फैक्टर का ध्यान दिया जाए, दवाइयों के बारे में बताया जाए. आई लाइक टू हैव एन ओपिनियन ऑफ डॉक्टर J.P. Sani. सर,
The cardiac rehabilitation program is a very important part of the management of heart attack patient who has received stent or he has undergone bypass surgery. We must learn कि हमने चाहे bypass किया है चाहे stenting की है, बीमारी को जड़ से नहीं ख़त्म किया है. The root cause of the disease remains. So there is always recurrences of heart attack, heart failure events in every individual who has undergone. So everyone has to go back to pavilion. So one cannot stay here. कोई अमर नहीं है after angioplasty or bypass. So we started a rehabilitation program 10 years ago in our hospital in Gangaram, and now is available in most of the institutions in the country also. So this is rehabilitation program has a very sound evidence from the studies that shows if you enroll the patient on cardiac rehabilitation program after heart attack, there is a 30% reduction in cardiovascular events for future. And this is divided into two parts. What we do in hospital rehabilitation and one is outside hospital rehabilitation. What we do, I have got a consultant with me, Dr. Madan now. He's also the chairman of the American Heart Association exercise program sitting in Delhi in India. So we have started this program. With that, what we do, every patient who undergoes angioplasty or bypass surgery or heart attack who has not undergone any intervention, all this group of patients pre-discharge, we call them to a teaching. So first part is education. A teaching class is done where the patient comes along with his relations and where we teach them about the cause of heart attack, what are the risk factors, and what are the important medications, and what are the rehabilitation, how much exercise person should do, so all these things are taught to the patient. So the patient gets the secondary prevention knowledge, and the relation gets the primary prevention knowledge about how to prevent heart attack in the family. Now this program is done, and then afterwards when the patient is discharged, we follow them up in the second phase of the rehabilitation where patient comes for exercise. Like those who are having bypass surgery with mild LV dysfunction, sometimes patient gets depressed. He doesn't want to go back to office. So the cardiac rehabilitation program helps us to put the patient back to his office as early as possible. So that gives us a real benefit to the patient. And in that part, what we do also is we look into the compliance of the drugs what patient is taking. And the second, we measure or monitor their risk factors, particularly the smoking part. Those who was a smoker, if you try to teach them that you have to discontinue, they will be always urged to smoke again or take tobacco. So that part with repeated counseling, we look after that. So in a nutshell, what I say, this is a program which really helps the patient to come back to his action as early as possible without any complication.
So I think the message is very clear by Dr. J.P. Sani that cardiac rehabilitation का जो थीम है वो बड़ा स्ट्रेट फॉरवर्ड है कि बहुत लोगों को डिप्रेशन हो जाता है हार्ट अटैक के बारे में, वो अपने आप को इनवैलिड समझते हैं, वो समझते हैं अब मैं काम करने लायक नहीं हूँ. तो दे बूस्ट द मॉरल, boost the strength in a patient, psychological strength. And he also mentioned one thing very important कि हम देखते हैं, मॉनिटरिंग करते हैं कि जो दवाइयाँ प्रिस्क्राइब करी गई उसका कंप्लायंस बराबर है कि नहीं, उसका अधीरेंस बराबर है कि नहीं, और मॉनिटरिंग करते हैं कि पेशेंट के अंदर जो तलब होती है स्मोकिंग की वो वहाँ तो नहीं जा रहा, कहीं शराब तो नहीं पी रहा है, फिर तो नहीं जा रहा कहीं फास्ट फूड के अंदर. तो ये सब चीज़ों की निगरानी रखते हैं, उससे रिकवरी फास्टर होती है. आई थिंक देयर इज़ अ नीड फॉर मैनी कार्डियक रिहेबिलिटेशन सेंटर्स in the years to come. I think it's a very nice message. To conclude, ladies and gentlemen, I must say with a great deal of confidence that this was the best session which I had in my life with a very eminent people here. Of attack, heart attack, time to act is now at a very nice platform of Tata Sky Fam Health. Ladies and gentlemen, I must tell you today, healthy heart is our dharma. Healthy heart is our karma, our metabolic karma. Healthy heart is our perception. Healthy heart is our thought. Healthy heart is our choice. It is in our hand. आप सोचें, जो डॉक्टर मनचंदा ने कहा, आप सोचें कि डॉक्टर आएगा अटैक करने के लिए हार्ट अटैक को, यू आर मिस्टेकन. आपको अवेयरनेस होनी चाहिए कि मुझे हार्ट अटैक हुआ, इसके क्या लक्षण हैं. डोंट गो टू ए अनक्वालिफाइड डॉक्टर्स, गो टू ए सेंटर हु इज इक्विप्ड विद द कार्डियक केयर, विद ए हार्ट स्टेशन. जैसा कि रवि कासलीवाल ने कहा, जहां हार्ट कमांड सेंटर हो, जहां स्पेसिफाइड बेड्स हों और प्री हॉस्पिटल क्लॉट लाइसिस के बारे में काफ़ी जानकारी दी गई. आई मस्ट टेल यू टुडे, save your heart is a mission of India, and you are all citizens of India. We all have to work together. Doctors plays a very important role, but the role is very limited. Dr. Manchanda categorically said that we all have to involve. It's not easy. It's a giant approach where everybody should be aware. Everyone should be aware of how to attack heart attack. ये एजुकेशन प्रोग्राम इज जस्ट ए इनिशिएटिव. इसको हम बार बार दिखाएंगे और इससे जानकारी होगी और उपचार में फ़र्क पड़ेगा. हमको उम्मीद है कि वी ऑल विल लर्न हाउ टू सेव ए हार्ट. Thank you very much for your kind attention, and I'm very grateful to each and every panelist who is with me, Dr. N. Khanna, Dr. Ravi Kasliwal, Professor Tiwari, Dr. Viveka Kumar, Dr. Vinod Sharma, Dr. J.P. Sani, and Professor Manchanda, sir. Thank you.